Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about hepatic infections. Now we'll start off with viral hepatitis. This is when the liver gets infected by viruses that specifically target it. These are called hepatotropic viruses. Hepatitis B and C are especially the most important because they can lead to chronic liver disease. Most of the time, imaging doesn't show anything unusual. The liver can look completely normal. But when there are imaging findings, the most common ones are periportal edema, where on ultrasound you would get a starry sky appearance due to the portal triad appearing bright. On CT or MRI, you might see fluid around the portal vein. Gallbladder wall thickening or edema can also show up. So these ultrasound images show a case of viral hepatitis. This sagittal image of the liver demonstrates increased echogenicity of the portal triads, appearing as numerous echogenic dots pointed to by these arrows. And these produce this starry sky kind of appearance. So you have the dark background of the liver and then the portal triads, bright portal triads appearing bright, being the stars. Then also the sagittal view of the gallbladder in the same patient shows marked diffuse gallbladder wall thickening. We can see that it's been marked by the calipers here, which is commonly seen in acute hepatitis. Now, pyogenic abscesses are usually caused by bacteria that travel from the gut to the liver through the portal vein. This often happens in people with diverticulitis, appendicitis, Crohn's disease, recent bowel injury. Now, E. coli is the most common culprit. On imaging, CT and MRI would show a ring-enhancing mass that can look like Mets. You may also see reactive hyperenhancement around the lesion. T2 hyperintensity in the center and restricted diffusion will also be seen on MRI. Now, these images show we have a T1 post-contrast fat suppressed MRI of the abdomen at the level of the liver here, and a portal venous face CT scan of the abdomen, axial cuts, both of them. And we can see a segment 6 lesion which shows peripheral ring enhancements and some enhancing components within. It's like septi or blood vessels coursing through or something like that. Something is enhancing within it. However, it has fluid signal within, low T1 signal. I didn't show the T2, but I had a high T2 signal. Then on the CT, we can also see this similar hypo-enhancing lesion with peripheral irregular ring enhancement and some enhancing components within as well. This was confirmed to be a pyogenic abscess. On ultrasound, the infection starts as a vague area of mixed echoes called the phlegmon, and then it develops into a well-defined hypoechoic mass with internal echoes. Now that's the matured abscess, moved from the phlegmon to matured abscess. There's also a subtype called cholangitic abscess, which can occur in patients with bacterial cholangitis, biliary stents, prior sphincterectomy, or hepatojejunostomy. These are caused by reflux of bacteria into the biliary tree from the stomach. So there's things will just reflux from the stomach into the biliary tree because of these procedures that have been done. Now, these images of the same patients that we saw in the previous, we now see this ultrasound that shows segment 6 lesion having a heterogeneous content. Same CT image we saw prior with peripheral contrast enhancement and restricted diffusion on DWI and ADC. We see this bright signal on DWI and a loss of signal on ADC, showing that it's restricting on ADC, and abscesses show restriction on ADC, on DWI and ADC. Now to tuberculosis. Tuberculosis can spread from the lungs to the liver through the bloodstream, causing granulomatous hepatitis. On imaging, TB can look like multiple small hypoechoic, hypo-enhancing nodules when we have the micronodular pattern, or larger masses with variable enhancement where we have the macronodular pattern, which is rarer than the micronodular pattern. The micronodular pattern can appear like the miliary pattern that we see in pulmonary TB. You may also often see hepatosplenomegaly alongside any of these findings, whether the micronodular or the macronodular patterns. So this image is a contrast-enhanced CT scan, and it shows multiple hepatic nodules with peripheral areas of low attenuation and central calcifications. I know these are calcifications because on the unenhanced, and I didn't show the unenhanced, they were still very bright as they are here. So it's not just contrast enhancement that we are seeing here. Biopsy of one of the hepatic lesions showed necrotizing granulomatous inflammation in keeping with macronodular type of hepatic TB. Now to fungal infections. When fungal infections show up in the liver, they show up as tiny punctate microabscesses on CT and MRI. These are usually hypoenhancing. On ultrasound, they appear as hypoechoic lesions. On MRI, they are typically T2 hyperintense and show restricted diffusion. Basically, the characteristics of abscesses, just that they are tiny microabscesses, multiple. If someone had a prior fungal infection or was exposed asymptomatically, imaging might show echogenic calcifications or granulomas, which is a sign of healed disease. So histoplasmosis, one of the fungal infections, is a specific fungal infection caused by Histoplasma capsulatum and is found in areas like the Ohio and Mississippi River valleys. It's more common in people with weakened immune systems, but healthy people can get it too. Liver involvement usually follows a primary lung infection, and imaging may show the usual fungal findings, that's the punctate microabscesses distributed throughout, and then you may have some hepatosplenomegaly as well, and you may also have some low attenuation lymph nodes showing up. Then to pneumocystis jirovecii, this usually also shows up in severely immunocompromised patients like those with AIDS. There's something unique where someone who was treated with inhaled pentamidine, which is used to treat pulmonary pneumocystis, could still develop liver infection because the pentamidine doesn't enter the bloodstream when it's inhaled. It just stays in the lungs and works in the lungs locally. So someone who had pulmonary pneumocystis treated with inhaled pentamidine would end up still having liver pneumocystis jirovecii. Now to candidiasis, another common fungal infection of the liver. It's also mostly seen almost exclusively in immunocompromised patients, and these infections can affect both the liver and the spleen, as we have come to realize with a number of these other infections, the opportunistic liver infections. So this image shows, with a non-contrast CT, it shows innumerable tiny hypoattenuating lesions scattered throughout the liver, and also we see some in the spleen pointed to by these arrows, and these represent candidal microabscesses in a patient who had a bone marrow transplant with fungemia. I mean, seeing these microabscesses could also be any of the fungal infections that we have also seen in the past, but blood cultures confirm candida in this case. Now, echinococcal disease or Hydatid disease happens when people ingest eggs of the parasite Echinococcus granulosus, usually in regions like the Mediterranean where sheep farming is common. These eggs can develop into Hydatid cysts in the liver. The imaging features on CT and MRI show a well-defined cyst with floating membranes or daughter cysts within this bigger cyst. You might also see peripheral calcification around the cyst. On ultrasound, the large cysts with many peripheral daughter cysts, which is a classic look, is also seen. And if you change the patient's position, the daughter cysts may appear to move. There's also the water lily sign. Remember on the CT and MRI, I mentioned the floating membrane in the larger cysts. It's also seen on ultrasound, and it's the same sign, the water lily sign, and it's an undulating membrane that is seen within the cysts. Another sign is the hydatid sand, which is fine debris from the cyst wall, which also appears to float within the cyst. Although there's a theoretical risk of anaphylaxis if the cyst leaks, many of these are biopsied and drained safely without any sequelae. The treatment is usually with albendazole or mebendazole. So these images are a case of hepatic echinococcus. The ultrasound shows a complex, primarily hypoechoic mass in the superior aspect of the liver containing a hyperechoic undulating membrane. And on contrast enhanced CT, we see a fluid attenuating cystic mass containing an undulating membrane as well, the water lily sign. This was an echinococcal cyst or hydatid cyst. Finally, we'll talk about amoebic abscesses, and they are caused by Entamoeba histolytica. This type of abscess almost always causes pain, and this pain is reported in about 99% of patients. It typically forms near the dome of the right liver lobe. And the tricky part is that on imaging, it looks just like a pyogenic abscess. So just go back and look at how pyogenic abscesses look like. Amoebic abscesses also look basically the same. It's just found out on aspiration and culture. The good news is antimicrobial treatment alone usually works, and drainage usually is not even needed. Thank you very much for your attention. I hope this was useful. If you did find value, share, give it a thumbs up, and subscribe if you have not subscribed yet. The next thing we'll talk about is cystic liver disease. I will catch you in the next one.